Good morning, and welcome everyone to our symposium, Mapping the Pathways to Long-Term Treatment Benefit in Chronic Lymphocytic Leukemia by PeerView and Health3 Foundation, CLL. This symposium is sponsored by Lilly, by an educational grant. I'm Paula Cramer, and I'm very happy to be here with two experts in the field of CLL, one from the US and one from UK. Professor Jennifer Wyack from Ohio State University in Columbus and Professor George Fallows from Cambridge. So please have your mobile phone ready because we will have some polling questions today. Where you can help us with your opinion on our questions. And also you are able to submit questions at any time, which we will be discussing in a Q&A session at the end of our agenda. This QR code is not for the questions. It is to access the web page and download the slides and additional materials, such as links to the guidelines, etc. The symposium will also be broadcasted again online on 25th of June. So you are welcome to join again or to ask your colleagues to join by then. Now, let's get started. Sorry. I have to tell you about what we will be discussing. So there's a lot of things that is going on in the field of CLL, and the topic of today is really how to best pick the treatment for our individual patients in the first-line treatment and also in the relapse refractory setting. This will be the topics of my two colleagues. And then we will look how looking into the future might influence also our first-line treatment discussions. Also, we will look at the different guidelines that are available, since there was a new guideline published only a few days ago. And then, most importantly, also, there will be a bit of bringing in the patient perspective on these questions of therapeutic sequencing. So now let's get started with two questions. Please scan this QR code, and then we will start the voting. So which are the factors that you think are relevant when deciding on first-line treatment? And please select all that you think are of relevance. Okay, so there's a lot of factors that seem to be relevant for you. We'll discuss later on. And now, since this symposium is also mainly on the sequential treatment strategy, how does that influence your selection of the first-line treatment? Really interested to see that answer. Okay, so a lot of people already think when deciding on first-line treatment what will come next. Thank you. We'll come back later to this. Now, as an introduction, I would like to remind you where we are coming from and that all these advances in the treatment of CLL have been made over the last decades. Only during the last 20 years, we introduced all these novel agents, and nowadays we mainly focus on targeted therapies. So there's very, very, very few patients or physicians that would still select chemotherapy or chemoimmunotherapy. And what type of therapies do we have? There's two large strategies that we have. One being the continuous BTK inhibitors. There's several different options. And on the other hand, we have the venetoclax-based time-limited therapies with a fixed duration. Now, looking at what comes in the sequence afterwards, you see here, if you start first line with a BTK inhibitor, you can, at progression, then either switch to the other type of treatment, the venetoclax-based regimen, mainly venetoclax rituximab, or you can switch to a non-covalent BTK inhibitor. However, if you stop due to adverse events, for instance, you can also re-challenge the patient with a different covalent BTK inhibitor. When looking at time-limited therapies as first-line therapies, you have the ability to re-challenge at progression, especially if the time between was long, or you can also do the switch to the BTK inhibitors. And we'll learn a lot about when to do what during the next talks of my two colleagues. So what is the best strategy of all these options that we now have available? We'll see the trial data later on, but is there any evidence from real-world practice? And I think the best data set from Europe was collected by the ERIC colleagues, and here you see different circles of the different treatment lines. The inner circle is the first-line therapies, and there you have to acknowledge that really the vast majorities of the first-line treatment in this data set is still chemoimmunotherapy. So this does not really apply to our treatment decisions as of today. So we cannot learn too much from this data set, but as you see here, when we look at different time phases before and after 2014, which is the time when all these novel agents became available, there is a huge switch. Yeah, you see that the orange bars clearly differ from the blue bars, which was before 2014. And just as an update on that, there will be a presentation on Sunday from the ERIC colleagues on this very question of sequencing, in this case, how venetoclax behaves after BTK inhibitor treatment. So I briefly alluded to it. We do have a new EHA guideline, and Jennifer will talk about that later on, but what I would like to focus on is the decision-making. So there's different factors that we should take into account when deciding on what kind of first-line therapy to use. One being, of course, the disease features. Is it high or intermediate or low-risk disease, defined by TP53, deletion 17p, and IGVH status? Sometimes we even consider the complex karyotype. Then, of course, there's patient-related factors such as renal function, comorbidities, concomitant medications, etc. And of course, it's also important to bear in mind what is the logistics of this treatment and what is the risks that the patient will face. However, in addition to these factors, there's something that we really also have to discuss, which takes a lot of time often, but which is really of high importance, and that is, what is the patient's preference? What's his or her preference towards a fixed duration versus continuous treatment, and with regards to all the logistics that come with these different therapies. So let's take a look at a patient survey that is currently still ongoing. It is performed by Health Tree Foundation CLL, and currently there's 73 patients in this data set currently, but it's ongoing. It is a data set that is reflecting all the different stages of disease. So there's patients who are still on active surveillance, some living with CLL for more than 10 years even, and some received one or several lines of therapy. And these patients were asked, so if this question on time-limited versus continuous treatment, if that played a role in the decision-making and the discussions with their physician, and the vast majority said yes, or not yet, but I expect to discuss this, so that's something that is in their mind. However, there's a considerable fraction of almost 20% of patients who do not recall or did not have this question discussed when deciding on treatment. And then this survey also continues questions about what are the most important factors for you, what matters most to you when making treatment decisions. And the very top thing is to keep the disease controlled over time continuously. However, things like avoiding side effects or being able to continue working or being able to take a break of treatment are of much less relevance, at least for these patients here in the survey. So I think that's kind of important to bear in mind, that really controlling disease is the key thing here. In addition, when patients were asked to select multiple factors that are important for them, then again you see that control of disease is of high importance, but also maintaining quality of life, daily activities, and then here it comes in achieving a deep remission and avoiding long-term side effects. However, the immediate things like avoiding hospital stays or taking a convenient or simple treatment is not as important as maintaining the quality of life and daily living activities and controlling the disease. Okay. So now we looked at the patient perspective, then let's look at the trial data. Welcome, Jennifer Warrior, to start with your talk on first-line treatment. Thank you.
Thanks so much, Paula, and good morning, everybody. I'm delighted to get to talk a little bit about some of the currently new and emerging treatment paradigms in CLL. So we'll talk about shifts in the treatment sequence for first-line therapy. Okay, so now make sure you get your phones out and answer this polling question. And we'll come back to some of these questions later on too. So first question, which frontline treatment strategy are you most commonly using today for fit patients with treatment-naive IGHV unmutated CLL without TP53 aberration? Are you using continuous therapy with ibrutinib, acalabrutinib, or zanubrutinib, time-limited venetoclax or obinutuzumab, time-limited BTK inhibitor plus venetoclax, or does this choice vary substantially based on the patient preference and comorbidities? Right, so we have a pretty wide variety. However, the majority of respondents right now are choosing a time-limited therapy or saying that this varies substantially based on patient preferences. Okay, next question. Which frontline treatment strategy are you most commonly using for older, frail patients? Again, treatment-naive, IGHV unmutated, no TP53 aberration. And then the answer choices are the same: continuous treatments, these time-limited options, or based on patient preferences. All right, and again, some variety here. Now we're seeing more use of the covalent BTK inhibitors, especially the second generation ones, still some time limited and still choice varying based upon patient preferences. Okay, last question. For an older, frail patient with treatment-naive CLL who may have limited tolerance for multiple sequential therapies, what would be your most likely frontline strategy to choose? Continue a second-generation covalent BTK inhibitor, time-limited ven-oben, time-limited BTK-ven, non-covalent BTK inhibitor, or again, choice dependent on comorbidities, support, and logistics. So good. So still some variety here with, I think, probably the highest percentage being the continuous second generation covalent BTK inhibitors, a few people choosing non-covalent BTK inhibitor, and then some time limited too. So I think that's really great. So we have a lot to discuss. Okay, so starting with new developments with frontline therapy and impact on sequential care. So Paula already alluded to some of the guidelines, and we'll talk about the EHA guidelines as well, but starting with the NCCN guidelines from the US, we see that in the most recent versions, recommendations for both time-limited and continuous therapy regimens for the majority of patients. So this is for patients without TP53 abnormalities. So the preferred regimens could either be BCL2 inhibitor-containing regimens, which are naturally fixed duration, or continuous covalent BTK inhibitor regimens. We have the other recommended regimens, which are the ibrutinib combinations, just based on tolerability, and then a few other things that can be useful in certain circumstances. For patients who do have TP53 abnormalities, we have really the same options, although I think kind of the preferences for this group of patients might be more skewed towards the continuous BTK inhibitors. But then certainly the BCL2 inhibitors containing regimens are appropriate here too. And here we do have the addition of MRD-guided approaches with venetoclax, acalabrutinib, potentially with obinutuzumab, and then venetoclax, zanubrutinib. And then the new EHA guidelines, I think these are really exciting because they even show more of this shift towards time-limited therapy. So you can see for those patients with who don't have TP53 abnormalities, both mutated and unmutated, kind of the first regimen options are these time-limited combinations. For mutated patients, primarily being ven-oben, for the unmutated, both ven-oben as well as the BTK inhibitor ven. For the 17p deleted or TP53 mutated, we have the second generation BTK inhibitors as the first listed regimen. And then Paula showed this before. I think also a really important way to think about these treatment options is, both the genetic risk of your patients, infection risk of the therapy, ease of treatment, so getting to these patient preferences, and then concomitant medications and comorbidities, which are increasingly playing a role as well. So moving to some of the data. So I think, one of the really exciting things that has sort of continued this movement towards fixed duration regimens is the CLL17 study, which was presented at ASH last year and simultaneously published. So this is the first study that was directly comparing all novel agents, but fixed duration to continuous ibrutinib. Important to note here, the follow-up is still very short. So we only have 3 years of follow-up here, but you can see at that time point, both venetoclax obinutuzumab and venetoclax ibrutinib were non-inferior to ibrutinib, and in fact, these curves are superimposed at this point. We're starting to see some interesting trends come up, in my opinion. Certainly none of these are significant yet, but for those mutated IGHV patients, the ven-oben arm has, at least numerically, the longest PFS right now. And then I think also importantly, although not significant at this time, when you're looking at TP53 altered patients, continuous BTK inhibitor, as well as a trend towards like the BTK inhibitor containing regimens looking promising. As well, we have the phase 3 Amplify study, which came out a couple years ago now, and this was the study of acalabrutinib plus venetoclax with or without obinutuzumab compared to chemoimmunotherapy. And again, very short follow-up here, but we're starting to see some interesting trends. So AVO looks very promising in terms of the progression-free survival. Unfortunately, there was a lot of infectious, especially toxicity with this regimen, so really patient selection is going to be key here. But we can see for those patients who have mutated IGHV, very good outcomes, again, with this follow-up with both AV and AVO. With IGHV unmutated patients, it appears at this time, again, that the addition of the obinutuzumab kind of negates that adverse prognostic impact of the IGHV unmutated status. And then, potentially looking forward at what might be an additional option in the future, the Celestial TN study, which is comparing zanubrutinib plus sonrotoclax to venetoclax plus obinutuzumab. So this is, again, an exciting study because it may lead to an additional therapeutic option for our patients. We saw some data yesterday from the studies looking at 2 different doses of sonrotoclax plus zanubrutinib, that this combination is producing very high response rates, very high complete remission rates, and undetectable minimal residual disease. And, important to note too, since venetoclax was initially developed, we've been concerned about tumor lysis risk. And we see really with the addition of anything to venetoclax that you give beforehand, you are reducing the risk of tumor lysis. And I think this has been especially exemplified with the BTK inhibitor lead-ins with either ibrutinib or with acalabrutinib. And here's data from, again, the Amplify study where the venetoclax was added in cycle 3. And you can see that for the patients who were high risk for TLS at baseline, the majority of them went to low or medium risk after the first 2 months of treatment. So another potentially paradigm-shifting movement that we're seeing in clinical trials right now is retreatment after time-limited therapy. So, one of the potential benefits to using these fixed-duration regimens in the frontline setting is that we may be able to give them more than once. And what we have seen from the initial studies, it's not on the slide here, but what we've seen is that when people do progress after these fixed duration regimens, we really have not yet seen the emergence of resistance mutations in BTK or BCL2, which suggests that these might be able to be used more than once. So these are some data from the Captivate study. So this was time-limited ibrutinib plus venetoclax, and they had 61 patients who progressed and then were retreated either with ibrutinib by itself or ibrutinib plus venetoclax. And you can see that the overall response rate was very high, very limited follow-up, but in the group that was treated with ibrutinib and venetoclax, the 1-year PFS and overall survival was 100%. In the patients that were treated with single-agent ibrutinib, 2-year progression-free survival of 91% with overall survival of 96%. So, so far that looks very promising to use the BTK inhibitor again. And then, there's also a lot of interest in these non-BTK inhibitor containing regimens like venetoclax or obinutuzumab. Could we just do the same thing again and save the BTK inhibitor or use the BTK inhibitor later? There is some smaller studies that I'll show you in a minute, but one of the ongoing trials looking at this is the REVENGE study, which has 2 cohorts of patients depending on their initial PFS following venetoclax or obinutuzumab. And then patients were given venetoclax or obinutuzumab again, either 1 year or 2 year, depending on their initial progression-free survival. So there was data presented last year at the summer congresses showing that for the patients who had completed treatment, most of them had achieved a remission with repeated venetoclax obinutuzumab. And as you can see here, many of those are actually a complete response or a clinical complete response. And many of them also had undetectable minimal residual disease. So this will be an important study as we have additional patients to look at and more long-term outcomes to see how effective this regimen is when given sequentially. We have minimal data from retreatment from some of the earlier studies. So this is data from the Murano study, which of course compared venetoclax rituximab to bendamustine plus rituximab in relapsed CLL. With venetoclax rituximab retreatment, the median progression-free survival was 23 months. So of course, shorter than what we saw with the initial treatment approach, which there the median PFS was about 55 months. And then in the patients who initially were treated with bendamustine rituximab, median PFS with the subsequent venetoclax rituximab is 27 months. So suggesting that in the relapse setting too, this is going to be an option. And then the other thing I want to bring up, which is starting to get more and more attention, is the potential upfront use of non-covalent BTK inhibitors in CLL, and this is specifically pirtobrutinib right now, based upon two trials that were presented at the ASH meeting last year, the Bruin CLL 314 and 313 trials. So this is the CLL 314 study, which was a head-to-head trial of pirtobrutinib versus ibrutinib. This trial contained patients with both treatment-naive and relapsed refractory disease. A third of the patients were treatment-naive. You can see here that in the intention to treat cohort, as well as specifically the treatment-naive patients in those third and fourth columns here, overall response rate as well as progression-free survival does favor pirtobrutinib. With the PFS, of course, it's important to note that the follow-up is very short here. Looking specifically again at the treatment-naive cohort here on the right, we again see that there is an advantage of pirtobrutinib compared with ibrutinib in this setting. So this, I think, is going to be really important to look at with longer-term follow-up. We also saw a favorable tolerability profile with pirtobrutinib. Again, this was expected based upon the previous studies with pirtobrutinib. Pirtobrutinib is an extremely selective BTK inhibitor, and thus was predicted, and what has turned out is that leads to a very favorable toxicity profile. So when looking at things like the cardiovascular toxicity, significantly lower with pirtobrutinib compared to ibrutinib. Bleeding was also lower with pirtobrutinib compared to ibrutinib. And then dose reductions were also significantly lower with pirtobrutinib than ibrutinib. Bruin CLL 313 was a head-to-head study of pirtobrutinib versus bendamustine rituximab, and so this was all treatment-naive patients. There was a crossover permitted to pirtobrutinib in the setting of disease progression, and I think that's important because what we have seen is that there was a significantly improved progression-free survival, as you probably expect for pirtobrutinib compared to bendamustine rituximab, but there also was a significantly improved overall survival, which is extremely surprising given the short follow-up and that ability of patients to cross over. So again, another really important study that we're going to have to look at in long term to see how durable these remissions with pirtobrutinib are in this setting. At ASCO and then here at this meeting, a presentation of a pooled analysis of treatment-naive patients from these two studies was presented. And I think, important things here. One is that the two studies were very similar in terms of the response rate in 24-month progression-free survival being about 93% in both of the studies. And as well, the toxicity profile was pretty similar between the two trials, low rates of grade 3 hypertension and all grade AFib or AFib at only 2.8%, which is lower than what we have seen with most of the other BTK inhibitors. And then discontinuation due to adverse events relatively low. Another exciting combination that has been presented at a number of meetings is the combination of pirtobrutinib, venetoclax, and obinutuzumab. The study was led by Dr. Jane at MD Anderson. And this combination was investigated in treatment-naive CLL. You can see here that the rates of undetectable minimal residual disease, and here UMRD 6, so a level 1 CLL cell per million cells is in gold, and in blue is the UMRD 4, so one CLL cell per 10,000 cells. And you can see that the levels of both UMRD 4 and UMRD 6 are very high with this regimen. And then most patients stopped therapy after 13 cycles. So far, they have not seen any progression. Of course, relatively short follow-up, so this will be exciting to follow in the long term as well. And then yesterday we saw the initial results of a study led by Dr. Inye An at Dana-Farber looking at a time-limited doublet of pirtobrutinib with obinutuzumab. And again, this was a study with relatively short follow-up. Response rates are very good. The undetectable MRD rate in the blood at the end of treatment was 52%, and a little bit higher when you only look at the patients who actually got to that time point and were evaluated. And then is what was hoped with this trial, low rates of infection and cardiovascular toxicity. So again, another approach that's going to be important to look at in the longer term. So with all of these options, with the current options that we have based upon the guidelines and these potentially emerging options that I just talked about, how do we choose between our time-limited approaches and our continuous treatment? So here are some of the factors that we use when we're thinking about these therapies. So in favor of time-limited approaches would be, of course, if the patient's desire to have some time off treatment. If that's the case, the frontline setting is really the best time to get a long-term disease-free remission, so that's the time to do your time-limited treatment. For those patients who are potentially older and have very good risk CLL, we think that some of these regimens are giving people, if not an actual cure, at least a sustained progression-free survival off therapy that might last their entire natural lifespan. Younger, fitter patients, I think, it's really important to think about time-limited therapies to prevent the emergence of resistance and to give them time off treatment. Of course, people have to be able to navigate the logistic challenges associated with this regimen, and for many people, this does require access to caregiver support. So then who would you give continuous therapy to then? So people who really desire simple, convenient at-home therapy. I thought it was really interesting in the survey that Paula presented, it was pretty evenly split, like the number of people who wanted a time-limited therapy or wanted time off treatment and the number of people who wanted to have a very easy therapy. So that's certainly something that is very patient-dependent. And of course, continuous treatment should be considered if clinic visits are going to be difficult or there's limited caregiver support. And then, of course, sequencing is really key, and it's really important to be thinking about sequencing when you're deciding what your frontline regimen is going to be. So in a time-limited approach, you do have the potential for retreatment and potentially extending the time before resistance might develop. Continuous approaches are likely to give you the longest disease-free remission in the frontline setting from what we've seen so far, at least for the majority of patients who have intermediate to high-risk disease. For those patients who have very low-risk disease, probably a time-limited approach is also going to achieve that goal. Okay, so now let's move into some cases. So we're going to start with Eric, and so I'm first going to discuss these cases with my colleagues up here, and then there'll be a few polling questions at the end related to them. So Eric is 82 years old. He has symptomatic treatment-naive CLL. He is frail and has limited caregiver support, and so he prefers to have a simple outpatient therapy that's not going to require a lot of back and forth to the clinic. In terms of disease features, he has unmutated IgHV, has wild-type TP53, has pretty bulky disease with a largest lymph node of 8.5 centimeters and an absolute lymphocyte count of 160,000. So again, he prefers simple outpatient care with minimal complexity. Of course, would like, as all patients do, a treatment that is effective yet well-tolerated. So I'm going to ask my colleagues here, maybe we'll start with Paula. What factors here might make this candidate for a good candidate for a continuous BTK inhibitor therapy over time-limited regimen? And I guess conversely, are there any factors that you think really would make you want to try to get him to do a time-limited regimen?
Okay, yeah, thank you for your excellent presentation and for reminding us of all the trial data. So as here it is already stated that the patient prefers a simple outpatient treatment, I think we are very much in the category of continuous BTK inhibitor treatment. However, I think it's worthwhile to still discuss with the patient what is really his worry about more intense treatment, and to really discuss the two options also of a time-limited BCL2 inhibitor-based treatment, which could also be a fully oral combination with a BTK inhibitor, so then ibrutinib or rather acalabrutinib for this elderly person, and to really discuss the logistics, etc., and the potential benefit of being then off treatment at some stage. However, I think it's also perfectly fine for this elderly person to go ahead with his wish and do BTK inhibitor continuous treatment. So.
Then, George, if you did make the decision to do a continuous BTK inhibitor, which one would you choose?
That's a great question, Jen. I mean, there are so many things that draw you to continuous BTK for this patient. Forgetting the molecular. He's 82 and frail. He's just going to have the tablets. In fact, I found myself thinking about the patient survey, the patients that were not really given a choice. I wonder whether this patient, if we're honest with ourselves, we're not going to start talking about I+V or A+V. I suspect he's just going to get the tablets. And I think it's a debate. In the UK, we've used more acalabrutinib than zanubrutinib, as much, I think, because of the run-in. And I could be drawn up on this. Perhaps there's a feeling that acala might be a little bit cleaner. I'll get told off for that, and both drugs are very good. And I think when you are 82, quality of life is absolutely essential. You're not planning for the future. I'm sounding very paternalistic, but you need them to get on with that drug now, and we've got a lot of experience. But with both acala and zanu, I suspect in our clinic we might give this guy acalabrutinib.
Go ahead. Yeah.
Yeah, I fully agree, but I would like to remind you of our frail study where we gave acalabrutinib to really these frail patients, continuous BTK inhibitor, and what we observed was the improvement in their frailty. And now for the next generation of these trials, we will try to find out if we can then add the venetoclax at a certain stage when they are not that frail anymore, and to offer to these patients to also discontinue treatment at some stage. So, yeah, we'll see.
Excellent.
Yeah, I think that's a really important study to bring up. And, you know, in addition to that improvement in the frailty, though, I think the converse was a lot of patients actually came off that study for toxicity, too. So suggesting, too, that, like, maybe trying to do something that is more time limited, though it of course like increases your initial toxicity. Maybe if a patient is not going to get very much therapy in general, doing something that is going to allow them more time off treatment would be beneficial too. And then of course, you know, thinking about just the natural lifespan of people, like how many lines of therapy is this patient actually going to receive? And I think we'd all probably agree, you know, if we successfully deliver our frontline therapy, this patient may only receive one line of treatment.
So maybe I can already ask one of the questions here, because maybe that's even where that would suit best, that came up. That was the question: for which fraction of patient would you consider non-covalent BTK inhibitors as first-line treatment? Thinking of that last point that you just mentioned.
Yeah, so I think, you know, that's, I think, going to be a really important question as we move forward. And I think, in my opinion, these frail patients are the ones who it's going to be very appealing to try to give something like pirtobrutinib, which is extremely well tolerated in the frontline setting. But longer follow-up, I think, is really going to be needed before we make that switch for everybody. So if all options were available, so this is a question for you guys now, how would you manage Eric's case? So again, 82 years old, frail, unmutated IGHV, limited caregiver support, who prioritizes outpatient therapy and tolerability. And you heard some different thoughts from us up here. Would you do venetoclax or obinutuzumab, ibrutinib, venetoclax, acalabrutinib, venetoclax, or one of the continuous BTK inhibitors? And if so, which one? All right, so you guys, just like us, have a lot to think about with these patients and would choose different things, probably a lot depending on patient preference. And we definitely see a skew towards the approaches that are either time limited but with acalabrutinib or the continuous BTK inhibitors. And and so even about a quarter of people thinking about pirtobrutinib in this setting. Okay, so with the last few minutes, we're going to discuss one more patient. So this is Christina. She's younger, so she's 68 years old. She has treatment-naive CLL, of course, and needs therapy. She also has unmutated IGHV and has wild-type TP53. However, in contrast, her priorities is she really wants to have some time off treatment and wants to do something that is going to maintain her excellent quality of life and not interfere with her lifestyle too much. So George, let's start with you this time. What would be your choice for this patient?
So definitely patient wishes come to the fore. We note the mutated, unmutated, that with all of our fixed duration therapies, the unmutated IGHV patients simply do have a shorter remission, but they can still enjoy a number of years treatment-free, and that does not dissuade us from treatment. I'll be honest, in our clinic, ibrutinib and venetoclax, we don't really offer that to people over 60 because of our concerns about toxicity from the trial. Acalabrutinib venetoclax will be appealing when that becomes available in the UK, but we have to also be fair. The data in the unmutated IGHV cohort in the Amplify trial were perhaps a little bit less encouraging with regards to progression-free survival. I think we would probably be offering this patient venetoclax obinutuzumab unless they had a particular issue with intravenous treatment or there were things that really went against it. We haven't talked about bulky lymphadenopathy, perhaps sometimes pushes us away. Or sometimes if patients have a particularly bad respiratory history, hypogamma, bronchiectasis, some things that I think the CLL17 trial drew out a little bit, that Veno does have more of an infectious profile that we have to be aware of. So I think those things would influence us.
That's great, thank you. Paula, to you. And I guess, I agree too. I think that Ven-Oben might be the option most likely to give a longer term remission for this patient. But how would you discuss the logistic aspects of Ven-Oben versus Ven-BTK inhibitor? And if you did choose the BTK inhibitor, what are kind of the challenges you see with initiating that?
Well, I wouldn't see too many problems because that's really the cohort of patients where we evaluated all these options. I am also not afraid of the ibrutinib venetoclax for patients above 60 in case they don't have any cardiac comorbidity history. We have to know about that risk and to monitor them, but I wouldn't say no to that treatment option for her. So because it was tested in CLL17 and we did not see these cardiac problems. So I think if we really know how to pick the patients, I think we can go forward with ibrutinib venetoclax also above the age of 60. We would start with the BTK inhibitor lead-in, and I think she will tolerate that well. And I would expect that by the time she would be about to start the venetoclax, that there wouldn't be so much of an issue with tumor lysis syndrome, etc.
Great. Well, thanks for the great discussion. Let's do one more question. So if all options were available, how would you manage this case? Again, 68 years old, unmutated IGHV, good functional status, prioritizes time off therapy. Venetoclax with obinutuzumab, ibrutinib venetoclax, acalabrutinib venetoclax with or without obinutuzumab, PBO, or continuous BTK inhibitor. All right, so as expected, most people are choosing a time-limited approach for this patient. Okay, so just a couple of closing thoughts. So, for our older, frailer patients, continuous therapy is likely our best choice right now, thinking about non-covalent BTK inhibitors in the future. And then, of course, really talking to the patient and caregivers about whether fixed duration regimens would still be supportive. For younger patients who want time off therapy, certainly we have a lot of great options for them. And then long-term follow-up from Amplify and CLL17 will really help us, I think, with these, especially the IGHV unmutated patients. So with that, we'll turn it over to George.
Thank you, Jen. What a great summary of the first line and also an introduction to sequencing treatment, particularly after time-limited therapy. Now, I'm going to be talking a little bit about sequencing after continuous BTKI to start with. And we thought the first question we would put to the audience was really, what is influencing our decision to treat? Because we've all got these patients in the clinic that are starting to relapse on their acalabrutinib, zanubrutinib, and it's quite variable as to what pushes us to make that decision to change treatment, because they might be well. We know that patients can gradually transition through the relapse setting. So we've put 4 options here. Are you influenced by high-risk molecular features? If they're an unmutated patient, do you move them on, or TP53 mutated? Are you sequencing in your lab? Does the presence of a BTK resistance mutation push you sooner rather than later? Is it clinical features? So perhaps I might include with that growing lymphadenopathy, which you might be influenced by depending on your sequencing if you're going to be using venetoclax or something next. Or is it a general decline in the patient's functional status, and would include by that, I don't know, just becoming less fit and frail. So those are 4 options for you to vote on. Interesting about so half of patients on clinical features. I must admit, I think that's where I would be drawn myself. So, and a couple more questions. So we're going to think of 2 different scenarios with BTK inhibition. So for a patient progressing after prolonged benefit, let's say this patient's had 5, 6, 7 years, and we've got the choices. So say they're on acalabrutinib, an alternative covalent. Would you switch them to zanu or ibrutinib? If they're actively progressing, would you take a break and then say, well, we'll re-challenge you again? Would you switch them to a non-covalent BTK inhibitor, pirtobrutinib? Or would you do a complete switch in target and go for BCL2 inhibition? And number 4 there is venetoclax monotherapy, or alternative venetoclax combined with antibody. So that is interesting, isn't it? So pirtobrutinib, 40%, 50% venetoclax combination. Yeah, it'll be very interesting to see how pirtobrutinib is going to change practice, particularly thinking of those patients who've been on drug, they're used to taking a tablet for years, and they may simply want to stick with that type of strategy. But I guess this is all new for us, so we're going to get more experience. But venetoclax combination definitely has been the standard. And then this one's a bit different. So imagine the patient, they've had relatively short-term benefit from their covalent BTKI. So imagine they're progressing after, should we just say a couple of years? And then we've got similar questions. So are we going to home in on really those options 3 and 5 were the most popular there, weren't they? I wonder whether less benefit from a BTKI is going to influence people to change their choices. Yeah, interesting. So I think that probably fits with the way I'd be thinking as well. If your patient has perhaps not derived such a long benefit from targeting BTKI, you might be tempted to go directly to target BCL2. So, as already been introduced, have the new European guidelines, which have just put a couple of slides on to remind ourselves. So these are, the first slide here is patients progressing on a continuous BTKI. So people stop a BTKI for either progression on the left-hand panel or intolerance. And we were having discussions about this yesterday about, so patients who are progressing, if they don't need treatment by IWCLL criteria, so imagine that patient is well, they're not got B symptoms, they're not anemic, etc., then the panel, and this is taken from the printed guidelines, so it says watch and wait with little a, and that A means continue your covalent BTKI until next treatment. So I think perhaps slightly misleading, because that doesn't really mean watch and wait as we as CLL doctors think of it. It means continue your covalent BTKI. I suspect that is a difficult area, because if you have decided that you're going to treat them with venetoclax rituximab, because that protocol goes straight into the venetoclax build, we do get a little bit nervous about tumor lysis, and all of us who are using venetoclax from time to time get significant tumor lysis issues, particularly in the relapse setting where you're not treating with an antibody lead-in, you're going in with your venetoclax. Even low-dose venetoclax can trigger tumor lysis, which is why we have to do it all so carefully. So I suspect if you've made the decision with you and your patient to go down that line, you might decide to go sooner rather than later. The alternative, which is now licensed and approved, is switching to pirtobrutinib, which is the licensed non-covalent for patients who have progressed on a covalent BTKI, and I guess that is an easier switch to make because it's just a straight tablet into a treatment effective dose. Now, the right-hand side of this panel is intolerance, and I think this is drawing out quite an important point, which I think most of us have really adopted internationally, that if you have a patient who's been on a BTKI, they're in a remission, but for whatever reasons, intolerance, patient's choice, I guess some parts of the world, financial influences might stop their treatment. If they have not progressed, there is no immediate need. I know the trials were all set up as continuous therapy, but if your patient is well, you can just observe them. However, if they are in need of treatment, then our guidelines are very clear. So VEN-R, the difference here on this side is we have the alternative. So if you're intolerant of Acala, you'd have the option of moving to Zanu, or of course ibrutinib to either of those two covalents, etc. Or the license does permit you to take the patient at that point to pirtobrutinib. So how about if you've had venetoclax-based fixed duration therapy? And so we've here got Veno, I guess VEN-R if that's been used, or Ven combined with the BTKI. So the same thing, are they relapsing? How unwell are they? Can you observe them still? And then this is the bit which I think all of us in the clinic have struggled a little bit with, trying to work out when is an appropriate time? How long do you derive benefit from that first remission before your retreatment? Because it is one of those old rules of oncology that when you reuse therapies, you tend to get shorter remissions, and I'm quite sure CLL will follow some of those rules. So if you've had venetoclax-based treatment and you've had a remission that's going to last 1 or 2 years, you might be less tempted to go down the venetoclax route. So that's the early. And so I think we're all fairly comfortable with, if you're relapsing within 1 or 2 years, you're likely to go on a BTKI. The later relapse is an interesting one because back to, I think, what Paula was saying, that patient preferences really are important. If your patient had a really easy journey with their venetoclax, the patient themselves will remember, actually, Veno was fine for me. And when you talk about the different options, they may very much prefer the idea of going back on venetoclax. Different antibody, different protocol, but that's something that they might feel familiar with. I think it is worth pointing out that there is no license approval for pirtobrutinib in this setting. So these patients who have not had a covalent BTKI, currently they have to have their BTKI would have to be a covalent BTKI. Now the US guidelines are a bit different, and I was presenting in a session on Wednesday with Jennifer Brown, and I did put her on the spot a bit, saying, how are the Americans allowed to use venetoclax obinutuzumab in relapsed? How is it preferred? And Jennifer said, it's a better antibody. And I said, well, we know that. But of course, the licensing trials were done in the first-line setting. So as Europeans, we are wedded to venetoclax rituximab in the relapse setting. But the US NCCN guidelines do permit venetoclax with obinutuzumab. Now, so patients progressing here, so continuous BTK progressing on therapy, BCL2, so this is pretty similar to us, but the antibody is a bit different. Intolerance, they come down the line here, and I think all of those options which we would have in Europe. And then what about after fixed duration? I think basically pretty similar. Progression on therapy or intolerance of venetoclax, I guess that does happen, not so commonly, but you'd be going on to your covalent BTKI. And likewise, if you're looking for where the non-covalent pirtobrutinib fits, it really is for patients who are progressing on BTK and BCLI. So these are those doublet therapies, not for patients who are progressing on during or after venetoclax obinutuzumab. So the sequential challenges for managing our patients who have been on covalent BTKI. Well, before we dive into some of the aspects about toxicity and why patients are stopping, I think it's worth reminding ourselves that BTKIs do have a toxicity profile, and there's a shared toxicity profile, infections, cytopenias, I think bleeding and bruising, we're familiar with all of them. There is this open question with all of our CLL therapies about second primary malignancies, and those of you who heard Kirsten Fisher present the long-term follow-up of venetoclax obinutuzumab, it is something we all have to be aware of. Of course, these are older populations, long follow-up, but the presence of solid organ malignancies and with all of our CLL therapies is something we have to look out for, not just skin cancers. There are a few more agent-specific side effects. I think in the relapse setting, we have prospective randomized trials of ibrutinib against acala and against ZANU, which has given us a bit of an insight into where some of the differences are. So ibrutinib, of course, we have more of the cardiac toxicity, and then some of the day-to-day things, arthralgias, diarrhea, which can be a bit more tricky. Acalabrutinib, the headaches we've got to be aware of, and I think that's certainly something to flag to the patients. ZANU, I guess there was some question about neutropenia in some of the trials, a bit more hypertension perhaps than acala, but these things we have to keep an eye out for. Pirtobrutinib, I think most of us in our clinics are getting early experience of this drug. We've used it in the UK more in the trial setting, but we've got a couple of non-trial patients now exposed to it, and it seems to have a pretty clean profile, and Jen has already shown some of the first-line data on that. But we know that when patients are stopping covalent BTKIs, it really is a mixture, isn't it, of toxicity and progression. We tend to see many of the patients stopping a covalent BTKI early are because of toxicity, and many of the patients stopping later tend to be progression. And this is a real-world data set that's predominantly ibrutinib, but came out of Canada and was presented last year at EHA. And just really mapping out 187 patients and showing that half of these people who are stopping, really a bit more than half, are stopping for toxicity reasons. And there is a bit of a debate as to what actually happens to these patients, what happens when you've stopped with your next line of therapy. And this is it just needs a little bit of explaining, because this is looking at the median time to next treatment or death from the start of the first treatment after the BTKI. So you've stopped for whatever reason. You may have had a variable length of time off treatment, but this is in the pre-pirtobrutinib era, of course, but looking at how long in the real world people got out of their next line of therapy, it is a bit disappointingly short, I must say. And it reminds us that although we have many options for our CLL patients, still with relatively modern data set, so I say that carefully, but relatively modern, patients in the real world setting are struggling to have long duration remissions. And then we've got data. So this is, I think, Ohio State, I don't want to confuse myself, but single real world analysis actually trying to give us a bit of a feel. And I think this is quite useful for our patients as to how long they might gain benefit if they have stopped a covalent BTKI for non-progression. So looking at people who've been on a BTKI, stopped for whatever reason, I think it's telling us what we've seen in the clinic, that patients who have been on these drugs for a long period of time, so this is over 2 years, tend to stay in a remission for quite a long time. Does that surprise us? No. I think these first-line patients who are pushed into a good long remission with acalabrutinib or zanubrutinib, etc., and you stop the drug, it does take 1, 2, 3 years for them to start relapsing. And that progression event of 28 months median doesn't mean they'll be starting their next line therapy, but actually we'll be starting to see progression. The converse is true, that patients who did not have particularly long exposure to the drug are not going to keep that remission for very long on average. And I think that is useful for us to tell the patients that we've got some real-world data sets that are telling us that that is what might happen. So in terms of a few principles when we're moving on from a covalent BTKI, I think there are a few points that we all agree with. I think I think it does influence practice more and more, this IGHV status. I know in routine community practice it is still not done so often, and we have that debate in the UK across our cancer networks, but you only have to test it once. So I think your case with Eric, I was reflecting about a frail 82-year-old, if we're being honest, is that type of patient going to get the full molecular profiling in the real world? I don't think they will, but it should be advocated for. We're certainly not ageist. I think testing for deletion of 17p and a mutational profile before each line of therapy is sensible. Remember, this is the one that can change. We were seeing some of the data yesterday reminding us that in the chemotherapy era, quite striking, the accumulation of 17p deletion in patients who are treated with chemoimmunotherapy. Perhaps we don't see that as much now with the novel targeted therapies, but that is still a bit of a watch this space. I think the basic principle of patients who are taking covalent BTKI, the basic principle remains if you're responding and tolerating, the advice is that you continue the BTK until progression or intolerance. There will be many individualized patients' reasons why you as a clinician and the patient may decide between you that that doesn't fit for them. But the standard advice is you continue. And then at progression, I think if a patient is progressing on a covalent BTKI, I think avoiding a treatment-free interval. We've seen that before, that if you stop the drug, the patients can progress quite rapidly. And I know in the real-world setting, if you're transitioning from a covalent BTKI to venetoclax rituximab, I and many of my colleagues have this debate as to whether rolling forward that covalent BTKI as you build up the venetoclax is just practical everyday sense, because as we know, some of those low doses of venetoclax in the relapse setting are not particularly effective, and there's always that nervousness. I always think it's like you've got a horse that's starting to gallop away from you and you're holding them back, and if you throw away the reins, we've all had that with CLL patients, that they can start to relapse very rapidly. So that's just something we have to bear in mind. I think doing molecular profiling to guide decision-making in this progressive setting is helpful. I think the advice remains that you shouldn't be changing your decisions based on a 481 mutation or something. We know that these can appear long before clinical progression, and I think that's something worth remembering. So when we're moving to this post-covalent BTKI setting, I think if we're talking about pirtobrutinib in the relapse setting, it's worth reminding us of this waterfall plot from perhaps one of the biggest phase 1/2 trials ever run. This huge number of patients who were given pirtobrutinib across various indications, but here we have 251 patients showing the change of lymph node size, reminding us that 80% of patients responding, having had prior covalent BTKI. But of course, you can't get licensed based on the phase 1/2 trial. You need the prospective randomized trial, and this was the 321, the international randomized trial of pirtobrutinib against investigator choice, and this is the progression-free survival plot. And this is quite a tricky group. Some of the patients I put into this trial had had many lines of therapy, 5+ lines of therapy, so heavily pretreated. And I always think when you look at these PFS plots, when you see these drops every 3 months, it's reminding us that quite a lot of these progressions were CT guided. There are a lot of scanning in this trial, and that, I think, reflects that clinical benefit can be more than you get from the impression from the PFS plot there, because we have a progression-free survival of 14 months. But when you look at time to next treatment, the trial were pretty good. They allowed us to roll, and we had a couple of patients who we could keep rolling on the pirtobrutinib. The patients weren't suffering from adverse events. They were comfortable staying with drug despite progression. And you can see the median time to next treatment here is an extra 10 months of 24 months, which I think reflects our experience with using the drug. Now, there's been a pooled data set which has brought together patients from the phase 1 trial and the 321 trial, looking at those who are being treated in the second line. And I guess that's no surprise that patients who've had less in the way of previous treatment are getting a longer progression-free survival when pirtobrutinib is used in the second line. Now, we can also use venetoclax, of course, in the relapse setting. We've already been introduced to some of this data. This is the Murano trial with venetoclax rituximab with these very impressive 54-month progression-free survival. These patients, the Murano trial was before the new therapies came along. The right-hand panel is perhaps a bit more representative, and this is, again, a large Ohio State data set, which was, I think this is the extension of the original Jones paper with now more patients here. And so we've got around 2 years of benefit for patients who had prior treatment with ibrutinib and treated with venetoclax. Now, this one needs a little bit of introduction. So Megan Thompson presented this at ASH a couple of ASHs ago. So this is patients who've had covalent BTKI, and then they had a non-covalent, so mostly pirtobrutinib, but a few nemtabrutinib patients. And then the question was asked, okay, you've had your covalent, your non-covalent, and then you start venetoclax. So that order of events, how did they get on? And of course, it's a retrospective, and the numbers aren't great, but we've got to take the numbers as we get them. So it's still 45 patients, multi-center data set, and showing that actually there is a signal here, the median 2 years, that perhaps this is telling us that how we order these drugs might not have a big impact. It's not prospective data, but it's the data we have. I think it's worth reminding ourselves this little bit here, tiny numbers, only 6 patients, but those patients who had previously had venetoclax, then covalent, non-covalent, and then back to venetoclax are perhaps not deriving the same benefit. So these patients really will end up becoming patients with significant need.
So it was really exciting that EHA was able to round off with the late-breaking abstracts that included Matt David's presentation from the Dana-Farber Cancer Center of the Bruin CLL 322 trial. Now, this really is an important trial for us in the world of CLL because it's looking at a new take on fixed-duration therapy, time-limited VR in the relapse setting. But in this trial, patients were randomized to either receive the standard 2-year protocol of venetoclax with 6 cycles of rituximab, or the same protocol, but having pirtobrutinib, the non-covalent BTK inhibitor, added into the mix. So it's a 1-to-1 randomization, over 600 patients, and 17 V-deleted patients were allowed in. And they were fairly heavily pretreated, so a median of 2 prior went into this study. The primary endpoint was progression-free survival, so robust, monitored trial with independent review. So jumping straight to the results, these created a lot of excitement. We had a clear progression-free survival advantage with a hazard ratio of about 0.55, reducing the risk of progression or death by 45%. It was a pretty well tolerated combination as well. If we look at the adverse events, the profile was fairly similar between the standard arm and the experimental arm, and the number of patients stopping for adverse events was similar between the two arms. In terms of subgroup analysis, it's interesting to see the different subgroups, whether 17p deleted or TP53 mutated and unmutated CLL. Some of these poorer risk patients actually seem to be deriving perhaps a bit more benefit from the addition of the non-covalent BTKI. And another really interesting part of this trial is that about 80% of patients had had a prior BTKI exposure. So it's a really representative study of what's going on in the real world in our relapse clinic. And those patients, even if they'd had progressive disease on a previous covalent BTKI, were benefiting from the addition of pirtobrutinib into the mix. There's data on undetectable MRD in the trial, again, looking favorably on PVR compared to VR. And so combined with an acceptable safety profile, I think this data does look to be establishing a new standard of care in the relapse refractory setting for those patients who are wanting fixed duration therapy.
So, case discussions. Christina, 68 years old, unmutated. So she had first-line VEN-I, we'll say. She had a 5-year remission, no TP53 deletion. And we put a few questions here which I'll put to the panel. You're all going to get to vote as well, and do please put your questions into Paula as they come up on the screen. So, Paula, double refractory, double exposed. She's had 5 years of remission. Yeah.
So she is certainly not double refractory, she's just double exposed. Yeah, she had 5 years of remission, which is really fine. Another thing I would like to remind you of, or I would like to discuss here, is if we now re-challenge her to a VEN-based treatment, would it really be fair to look at PFS of VEN-based treatment, time-limited versus continuous treatment? So if she receives another round of venetoclax and responds again, has another, maybe not again 5 years, but 3 years, for instance, then this would then add up to 8 years. So that is also something that is really a long time period. So really, I think we also have to bear in mind what endpoints are we looking at, and is it fair to compare apples and oranges, a continuous treatment versus a time-limited therapy. So definition of double refractory is, I think, something that we need to be better on. We really don't have a clear definition. With the EHA guidelines now have the 2-year threshold for repeating the same type of treatment in the context of time-limited therapy, but for refractoriness, I would rather say this should be defined by progressing on treatment or very closely afterwards, so rather a 6-month threshold would be my definition.
Thank you. Now, Jen, I'm going to put the next question to you because we allowed ourselves to be either retreated with BTKI Ven, which of course is not approved in Europe, but we do think everything is possible in America. So if you are making the decision, what would influence you for one of those approaches?
Yeah, I think this is hard because obviously there is not a lot of data to help guide what you should do next. Certainly, I think it would be reasonable to treat her again with a covalent BTK inhibitor and venetoclax, and I'm sure we could get it approved by insurance in the U.S. And if she tolerated this very well, if she, obviously she had a great remission duration with it, I would be tempted to do this again. However, at the same time, you might get a longer response if you switch to a Ven-Oben regimen at this point. And I know in other parts of the world you would also do Ven-rituximab there. I would still do Ven-Oben here. And I think that just you probably would get a longer remission if you switched to a different partner with the venetoclax. And then certainly too, though, she would do well if you treated her just with a covalent BTK inhibitor at this point. And so I think there is, obviously still a lot of options depending on patient preference.
Okay.
Maybe I can add something on that. When you think about the 322 data, even though we only saw them, that would also be
absolutely
an option in this setting. Yeah. I think that's really attractive because that's the thing that patients will ask for when they received then BTKI. We are really facing difficulties in Germany because we cannot offer that in the relapse setting.
Yeah, no, I think that will influence practice. So we're putting the question to the floor. So we've just seen that case. 5-year treatment-free interval. We've got our options. Retreat with BTKI venetoclax, if you could access that. Continuous BTKI. A time-limited combination with ven and obinutuzumab, presumably, or rituximab. Single-agent ven, or switch to Perto. So if we can just start the voting on that one, see what the audience think. Venetoclax, obinutuzumab, or venetoclax rituximab, depending on what part of the world you're in. It's interesting, though, isn't it, that a quarter of delegates would go for just the retreatment. So 5 years clearly does feel to our audience that they've had more benefit. Now, imagine the patient. Sorry, this is just, let's twist it around a bit. A 3-year remission this time, so shorter remission, and this time Christina's been a bit unlucky because she's picked up a 17p deletion at progression. Not so common, but it has happened now. Paula, 17p deletion, does that trump everything? Does that now drawing you to continuous BTKI, or how would your fixed duration mind think about that?
Well, I would discuss the data with her, yeah. If she is really into, again, doing a time-limited therapy, I wouldn't talk her out of that, because still, if she progresses, we then still have the BTK continuous treatment option at that time. So, but deletion 17p especially would rather favor the continuous treatment at that time. So that would be rather my recommendation here. Yeah.
And Jen, of course, we haven't seen the 322 data properly, so it's very unfair of me to ask whether that would draw you more into that type of protocol.
Yeah, I think if I was going to do something time limited at this time, I would probably favor doing the triplet of PVR, just thinking like if we could do something a little bit more intensive, we're likely to get a longer remission. Though I agree with Paul, I would probably choose a continuous BTK inhibitor covalent right now.
Okay. My last case, Gustav, prior treatment, acalabrutinib, durable remission, and he's starting to relapse, 71, unmutated IGHV. We talked about this before. I think to keep things moving, should testing for 70p be repeated now? I think we all agree, yes. Now, BTK mutations, is that going to influence your treatment choice? So let me put that to you, Paul. Imagine he's got a C481S mutation and he's progressing on ACALA. Is that going to push you one direction? Would it push you more towards venetoclax? Or would it push you more towards pirtobrutinib?
Of course, yeah. I think in case you have patients progressing on BTK inhibitor, you should look for these resistance mutation and then decide what to do next based on what you find there. Sure. That's the situation where we should really go for that.
And Jen, in the US, deep sequencing everybody?
Everybody, all the time.
Everybody, every clinic gets it.
Every week.
No, I agree, though. I think that the BTK mutations in this setting is particularly helpful, and PLC gamma 2 as well. Because with acalabrutinib, I think we're seeing a little bit more of the T474I, the gatekeeper mutations, than we do with ibrutinib. with ibrutinib, we tend to see more PLC gamma 2 mutations, and some of these mutations that might convey resistance to, or confer resistance to pirtobrutinib. Not that I wouldn't use pirtobrutinib, but I would probably just be thinking about, what's going to be the next treatment option after that.
Excellent. And then there are a few other questions here which I think we can get moving. I think that question on there, would you consider a time-limited Perto-Venar? I guess this is going to be quite a conversation topic going forward after this EHA conference. What if Gustav discontinued due to intolerance? Jen, I'm sure in your practice, if he just stopped because of intolerance at 6 years, you would just be observing him if he was still in remission.
Yeah, absolutely.
Yeah. And I think we all would be doing the same thing. I think in the interest of time, we'll move on and we'll put the question to the floor. So 71-year-old Gustav, a few comorbidities, 6 years of acalabrutinib progressing. I wonder what the audience will choose, having heard that bit of discussion. Interesting. So 25% are voting for a combination regimen that we haven't even seen presented yet. I'm not disagreeing with that, but if Matt David's going to remember, Matt, I did not present your data. We just looked at the slide. We will see it all tomorrow. But it is interesting, isn't it? So a third of people would just switch them straight to pirtobrutinib. It'll be very interesting to see how this pans out in actually the real-world setting, whether our patients and the clinicians are going to want to simply convert. So these are just some closing thoughts on the cases. I know that we do have 10 minutes for general discussion coming up. We talked there with Christina with a break in therapy, and we talked a little bit about the 3 years, 5 years, and how I think the patient's preferences really do win out. But a long period off therapy after fixed duration would really draw you back towards fixed duration therapy. And then perhaps a more elderly patient with comorbidity, I think this type of territory may well be more preferable for patient and clinician to just stick with continuous, but we'll have to see. So I am now handing over to Paula, or Paula, are you chairing this from where you're sitting? Should I? Yeah, and I'll hand over. Thank you.
Thank you. Thank you, George. So, no, I have to go over there to open the slide. It's only one last summary slide. I would really like to remind you, in spite of the fact that we now talked a lot about sequencing, that really the vast majority of patients will only need 1 or 2 therapies, and there will even be a lot of cases where we only do the active surveillance. So the majority of patients, I think we are already very, very good with our therapies. And when it then comes to first-line therapy, this is really the window of opportunity to really pick the right thing at that stage. However, there is situations where we really need to think of the future, the next lines of treatment, and that is especially the very young patients and those with adverse prognostic factors. And I think in these cases, really, you have to think of the upcoming lines of therapy, what will come next, or even afterwards. We also discussed about the differentiation between prior exposure and refractoriness, especially when deciding on if we can re-challenge a patient with some sort of treatment. And then, in addition to all the factors that you see in the guidelines, comorbidities, disease biology, risk factors, it is especially the patient priorities that we have to discuss with them. And it is really key to consider the quality of life, and this can be different between patients, as we saw also with our cases. For some, it's just having an easy treatment without a lot of appointments, and for others, it's having time off treatment. So it is really key for us to discuss this with our patients together and decide on that. Okay, so this is my final notes, but we do have a lot of questions, and we have an additional 10 to 12 minutes to discuss all these questions. I had a hard time to pick the right ones, but some were covered already, I think, during the case discussions. So now, for you, Jennifer, there were several questions regarding what is really the difference between EHA and NCCN guidelines. We already discussed the point of VEN-OBI, which we would really like to have for the relapse setting, but where's the additional other differences that you would like to point out to us?
Yeah, I think when I'm looking at the guidelines, they actually are very much in alignment. To me, the biggest difference that I see, and especially in the frontline setting, is more of a shift toward time-limited therapies in the EHA guidelines, where the NCCN is still relatively open between time-limiting and continuous therapy, again, for those patients without TP53 abnormalities. And we'll see, with subsequent iterations of the NCCN, whether those change and become even more in line. And I think also there is not as much emphasis placed in when to switch therapy, I think, in the NCCN, in terms of for the patients who are slowly progressing on the BTK inhibitors. That's not something that has really been addressed in the US guidelines.
Okay. And I think something that we also did not cover so much here is the question which patient qualify for triplet therapy, so mainly the AVO. Where would you consider this?
Well, in the UK, we won't have access to AVO.
So it's a question for you again. Sorry.
Yeah, so I think I have not. I have been preferencing triplets for young, fit patients who have IGHV unmutated disease, or occasionally for the patients who have TP53 altered that really would like to have a fixed duration therapy. I think for the mutated IGHV, with the follow-up we have, AV and AVO look relatively similar, so it's hard to choose a regimen that has more toxicity. But I think with what we know so far for the unmutated, there does seem to be an advantage to the triplet. So in a patient who I think can tolerate it, I'm considering that regimen. We also saw, again, more of a U.S. allowed interpretation, but at ASH last year we saw some data on delayed OBIN with acalabrutinib and venetoclax potentially limiting toxicity too. So I've actually started to incorporate that into my practice somewhat as well. And for some patients who I'm not entirely sure if we're going to do well with the complete triplet, starting with AV and then considering the addition of the obinutuzumab in the second half of the therapy.
Yeah. And talking about triplets, what's your idea of the concept of functional cure? How would you define that, both of you? What would be the criteria? Do you feel comfortable to talk about cure as a goal, or?
I really think that we do. I think that we are at least functionally, if not actually, curing some older patients with lower standard risk disease. And to me, it means that the patient is not on therapy, is not requiring therapy, but also does not have a detectable disease clone. Because I think that I don't think we can call it a cure if we're still seeing evidence of disease, knowing that that's probably also, harming their immune system in other ways.
Yeah, no, I really enjoyed the debate yesterday with Stefan Stilkenbauer and Talman here. Because the one thing we haven't talked about in this session, obviously, is the flare strategy of I+V, which I must say in UK private practice we can use. And so for our younger patients with unmutated IGHV, that's become a real favourite of mine. Because I buy into Tal's side of that argument, if some of you are hearing that debate about this potential of, I really use those words carefully about functional cure, but because there is no point on your deathbed dying of a heart attack at 68 going, I was cured from CLL. That's not a win either. So we do want them to live a long, long time. So,
yeah. So you said undetectable MRD should be the goal then for defining functional cure, but how? What type of measurement and what compartment?
Well, I mean, that was part of the debate yesterday,
Yeah.
and I think Stefan's point about actually using MRD to change practice and using it in routine practice right now is just not to be advocated. It can create a lot of confusion for both clinicians and patients. It's a tremendously powerful tool for many reasons that we all know, understand, and we really hope that MRD-guided therapies with some of the big trials that are ongoing is going to influence practice. The only reason I cited FLAIR, because I think in that, I'm personally convinced by the argument that if you've got people fit enough with the right molecular profile who you can put through that protocol, the data as it stands, I think is good enough for me to make that change. But I'm not advocating for it in routine practice.
Yeah. Okay, there's several further questions. I really have a hard time to pick them, but if there is questions here in the room that were not put into the system, you can also go to the microphone if you would like to. So another question, I think, which is really key is now we have the EHA guidelines with this 2 years interval for defining retreatment opportunity. Is that something that you feel is sufficiently supported by data? And what data is that? Or would you pick a different threshold? Or what's your
the data is, as we know, relatively thin.
Yeah.
And I think it's just fitting with what we all feel intuitively, that if you've got less than 2 years with a fixed duration, the chances of you getting more than 2 years the next time round are pretty slim. But I think back to some of the points that Jen's made, Paula, you've made, the patient themselves and their view will be critical at that decision point. But we, obviously in the UK, we cannot access venetoclax BTKI in the relapse setting, so that type of thing influences a little bit.
Sure. And for you
I mean,
also
I guess
agree to that?
in a guideline you have to come up with some sort of cut point. So, and I agree though, there's not a lot of data to support 2 years, and I honestly would have a hard time retreating somebody who had 2 years and 4 months remission after a ven-based regimen too.
Yeah, I kind of like the idea of having in mind what would be the median progression-free survival that you would expect for that situation with this type of risk factors, and did the patient achieve that period or not?
Yeah.
But
And hopefully
that's
after
to
Revenge, we'll know
Yeah.
that it's hard without any data.
Yeah, sure. So speaking of the very high-risk patients with TP53, deletion 17p, maybe also a complex karyotype, there were also questions on, is it still valid to go for ven-based therapies? What's your opinion on that? Our cases did not have that in the first-line setting.
I think the international community has been drawn into continuous BTKI for these challenging patients as much because it's hard to support with evidence-based other strategies. I think you can hand-wave molecular arguments that these more proliferative clones, they're capable of acquiring more genetic resistance and things, and keeping them suppressed, keeping that clone number small might be better than going through rounds of proliferation, amplification, acquisition of more difficult genomic problems. And there's always that hope that you have the discussion with the patient, and I say, well, you know, the world is changing. That's what you're going on this drug, but it's remarkable, the new therapies we have now, that if we'd had this conversation 10 years ago, we wouldn't have been aware of them. And it is sometimes the argument of the destitute, as I say, that you're coming up with logic. But I think based on the data we have, continuous BTKI is what we do in our practice, and I think can be supported with data.
Yeah. Maybe as the last and very practical question, it is directed to you, George. What do you do if a patient develops atrial fibrillation and needs anticoagulation on covalent BTK inhibitor? What would you do? Would you discontinue the BTK inhibitor or dose reduce or dose
So I'm definitely
reduce
influenced by if they are clinically unwell with the AF, then inevitably you'll end up stopping the covalent BTKI. But some patients, as we know, they'll pop into their grade 1, 2 AF, and some elderly patients are remarkably symptom-free. I must admit, I talk to my cardiologist. I know you're meant to use standard dose DOAC, and I'm obviously not advocating for below that, but I just have a bit of a thing. I tend to start the first month at half dose because I take the view, if my cardiologist tells me they have a 7% annualized risk of stroke, and I think to myself, well, the first month or two, if they're on half dose, to see whether they're a bleeder, because patient variability on bleeding is enormous with BTKI. Some patients can be full dose apixaban, which tends to be our favourite. Some patients will bleed, other patients will have no bleeding problems. I think for me it's a bit personalised.